Pituitary apoplexy. Int. Introduction. The word apoplexy comes from the Greek apoplexia, meaning a seizure, in the sense of being struck down. In Greek, plexia is a stroke. The ancients believed that someone suffering a stroke had been struck down by the gods. Apoplexy, a sudden neurologic impairment, usually due to a vascular process. Introduction. Pituitary apoplexy, sudden onset of headache. Visual symptoms. VFNVC, optic nerve or chiasm. Ocular motility, cranial nerves and cavernous sinus. Altered mental status. Hormonal dysfunction. There is usually an existing pituitary adenoma present. Pathophysiology. Stems from an acute expansion of a pituitary adenoma or, less commonly, in a non-adenomatous gland, from infarction or hemorrhage. Some postulate. Gradual enlarging pituitary tumor compressing and distorting the hypophyseal stalk and its vascular supply, causing ischemia and subsequent necrosis. Another theory, rapid expansion of the tumor outstrips its vascular supply, resulting in ischemia and necrosis. Doubtful. Tumors that undergo apoplexy are slow-growing. Frequency, this condition results in an estimated 1.5 to 27. Frequency, this condition results in an estimated 1.5 to 27.7% of cases of pituitary adenoma. Sex, male to female predominance is 2 to 1. Age, the age range is 37 to 57 years. Clinical manifestations. Headache in 95% of cases. The headache is sudden. Frequently, it is retroorbital in location and may be unilateral at onset, then becomes generalized. Vomiting occurs in 69% of patients and often accompanies the headache. Clinical manifestations. The classic visual field defect is a bitemporal superior quadrantic defect. Ocular paresis, 78%, results from compression of the cavernous sinus, which make cranial nerves 3, 4, 5 vulnerable to compression. Diplopia may be present. Of the cranial nerves, the oculomotor nerve is involved, most commonly unilateral dilated pupil, ptosis. Less commonly, cranial nerve 4 is involved. Clinical manifestations. Horner syndrome may develop from damage to the sympathetic fibers. Involvement of the hypothalamus may alter thermal regulation. Destruction of adenohypophyseal tissue may lead to endocrinologic deficiencies. Predisposing factors. Predisposing factors, endocrine stimulation tests, bromocriptine treatment, head trauma, pregnancy, and pituitary irradiation. Some believe, more prevalent in patients who produce excess pituitary hormones, e.g., acromegaly, Cushing's syndrome. Because the tumor is fueled by the hormones. Others, most pituitary tumors that undergo apoplexy are endocrinologically silent. Sheehan syndrome. Sheehan syndrome refers to pituitary apoplexy of a non-tumorous gland, presumably due to postpartum arterial spasm of arterioles supplying the anterior pituitary and its stalk. In 1937, Sheehan reported 11 cases of women who died in the puerperium. 11 necrosis of the anterior pituitary gland. 9/11 severe hemorrhage at delivery. 211 no hemorrhage but were gravely ill prior to delivery. The pituitary gland hypertrophies in pregnancy. This hypertrophy combined with locally released factors mediate vascular spasm more susceptible to infarction from compromised blood flow. Sheehan syndrome, inability to lactate, prolactin deficiency. Amenorrhea, gonadotrophin deficiency, skin depigmentation. Hypothyroidism. Hypoadrenalism. Diabetes insipidus, posterior pituitary involvement. Imaging studies, CT scan and MRI. MRI is the most sensitive imaging study for evaluating the pituitary gland, possibly visualizing hemorrhage not seen on CT scan. In the first 3 to 5 days, hemorrhage within the cella is iso-intense or hypo-intense on T1 weighted images. On T2 weighted sequences, the blood appears hypo-intense. Imaging findings: CT, CT-. Acute, cellular/supracellular mass with patchy or confluent hyperdensity, may associated with SA. Chronic empty cella filled with CSF. CT+, minimal or no enhancement, rim pattern suggestive of PA. Imaging findings: Mr. T1: early acute, enlarged gland, iso/hypointense with brain. Late acute/subacute hyperintense. Chronic hypointense. T2: acute, enlarged, hypointense, hemorrhagic, or hyperintense, non-hemorrhagic, pituitary subacute hyperintense. Chronic hyperintense. T1+ rim enhancement, case 69 years/O male headache, vomiting. Ptosis, LTEM limitation medial. Fever antibiotics, subsided after steroid usage. Ptosis persistent transfer to NS for operation. Pathology report: pituitary adenoma. Case CT-, a cellular lesion with slight high density. CT+, without obvious intralesion enhancement. Case T2 T1 T1 GD+. Mixed signal intensity on T1W, T2W images. Hematoma content is suspected. Mild contrast enhancement. Sudden onset of severe headache, non-projectile vomiting. 46-year-old man. Sudden onset of severe headache, non-projectile vomiting, followed by high fever and cranial nerve palsies. A large heterogeneous mass, highly consistent with a hemorrhagic macroadenoma. Infect Med 1712, 806,810,811, 2000. Pituitary apoplexy, an overlooked cause of fever and CNS abnormalities. Pre-contrast T1, a heterogeneous mass in the cella. T2 and flare, heterogeneity of signal, consistent with hemorrhage and or proteinaceous debris. Post-contrast T1, no detectable enhancement. The normal caliber left cavernous carotid, first image. Narrowed right cavernous carotid, following 3 images with arrows. Treatment: administer high-dose corticosteroids. Most patients have hypopituitarism. Hydrocortisone 100 mg initially, then Q6 8 hours until surgery. Evaluate electrolytes, glucose, and pituitary hormones. Administer appropriate endocrinologic replacement therapy alone, or combine with transvoidal surgical decompression of the tumor. Thank you for your attention.